Welcome to the March 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 5 scientific articles published in the March issues of the journal, as well as a commentary by Dr. J. Lawrence Marsh on the article entitled Dynamic Stress Testing is Unnecessary for Unimalar Supination External Rotation Ankle Fractures with Minimal Fracture Displacement on Lateral Radiographs. Be sure to check out this month's Current Concepts Review article on anatomy and biomechanics of the native and reconstructed anterior cruciate ligament, Surgical Implications by Dr. Matthew Krautler and colleagues. The authors note that technical errors, such as non-anatomic tunnel placement, are among the most common causes of graft failure after anterior cruciate ligament ACL reconstruction. No clinical superiority has been demonstrated for double bundle ACL reconstruction compared with single bundle reconstruction. Regardless of surgical technique, single bundle compared with double bundle, or anteromedial portal compared with transtibial, the surgeon should avoid placement of a vertical or low femoral tunnel, as this results in abnormal knee kinematics. The authors highlight the findings of the current literature on ACL biomechanics, the surgical technique for ACL reconstruction, as well as the advantages and disadvantages of common graft types, and they offer surgical suggestions based on the best available biomechanical and clinical data. In this issue, JBJS.org presents a new image quiz, a 16-year-old boy with pain in the right shoulder. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Relationship Between Patient-Reported Assessment of Shoulder Function and Objective Range of Motion Measurements by Dr. Frederick A. Mattson III and Associates. Investigation performed at the University of Washington, Seattle, Washington. Assessment of function is the cornerstone of clinical shoulder research. The purpose of this study was to answer 3 relevant questions. How does subjective patient assessment of shoulder function correlate with objectively measured active shoulder range of motion? What is the difference in active motion between shoulders that can and those that cannot be used to perform each of the functions of the Simple Shoulder Test, SST? Does the relationship between subjective and objective assessment of shoulder function differ between male and female patients? The authors analyzed the relationship between objective range of motion measurements recorded by the Observer Independent Connect Motion Capture System and SST patient self-assessments of shoulder function of 74 male and 30 female patients with osteoarthritis. There was poor correlation between objective measurements of active abduction and total SST scores of osteoarthritic shoulders of patients seen before shoulder surgery. The coefficients of determination, R2, were 0.29 for the osteoarthritic shoulders of women and 0.25 for those of men. The relationships between active abduction and total SST score were closer for the contralateral shoulders. The difference in active abduction between the osteoarthritic shoulders that allowed and those that did not allow the patient to perform the individual SST functions was significant for only 4 of the 12 functions in the female group and 5 of the 12 in the male group because of the highly variable relationship between self-assessed function and active abduction. In contrast, when the contralateral shoulders were assessed, this difference was found to be significant for 10 of the 12 functions in the female group and all 12 of the functions in the male group. The relationship between objective motion and subjective function did not differ significantly between male and female subjects. Conclusions. The self-assessed function of osteoarthritic shoulders of women and men is only partially determined by the active range of abduction. Both subjective and objective measurements are important in characterizing the clinical status of shoulders. Studies of treatment outcomes should include separate assessments of these 2 complementary aspects of shoulder function. Next, you'll hear the second abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Oral and Intravenous Tranexamic Acid are Equivalent at Reducing Blood Loss Following Total Hip Arthroplasty, a randomized controlled trial by Dr. Erden Kayupov and Associates. Investigation performed at the Rush University Medical Center, Chicago, Illinois. Tranexamic acid is an antifibrinolytic that has been shown to reduce blood loss and the need for transfusions when administered intravenously in total hip arthroplasty. Oral formulations of the drug are available at a fraction of the cost of the intravenous preparation. The purpose of this randomized controlled trial was to determine if oral and intravenous formulations of tranexamic acid have equivalent blood-sparing properties. In this double-blinded trial, 89 patients undergoing primary total hip arthroplasty were randomized to receive 1.95 grams of tranexamic acid orally 2 hours preoperatively, or 1 gram tranexamic acid intravenous bolus in the operating room prior to incision. 6 patients were eventually excluded for protocol deviations, leaving 83 patients available for study. The primary outcome was the reduction of hemoglobin concentration. Power analysis determined that 28 patients were required in each group, with a plus or minus 1.0 grams per deciliter hemoglobin equivalence margin between groups, with an alpha of 5% and a power of 80%. Equivalence analysis was performed with a 2 one-sided test, in which a p-value of less than 0.05 indicated equivalence between treatments. 43 patients received intravenous tranexamic acid, and 40 patients received oral tranexamic acid. Patient demographic characteristics were similar between groups, suggesting successful randomization. The mean reduction of hemoglobin was similar between oral and intravenous groups. Similarly, the mean total blood loss was equivalent between oral and intravenous administration. 3 patients in the oral group and 1 patient in the intravenous group were transfused, but the difference was not significant. None of the patients in either group experienced a thromboembolic event. Conclusions. Oral tranexamic acid provides equivalent reductions in blood loss in the setting of primary total hip arthroplasty at a greatly reduced cost compared with the intravenous formulation. Next, you'll hear the third abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Role of Weekly Teriparatide Administration in Osseous Union Enhancement within 6 months after posterior or transforaminal lumbar interbody fusion for Osteoporosis-Associated lumbar degenerative disorders, a multi-center prospective randomized study by Dr. Shigeto Ibata and Associates. Investigation performed at the Departments of Orthopedic Surgery and Health Science for Clinical Medicine, Graduate School of Medicine, University of Yamanashi, Chuo Yamanashi, Japan. Department of Orthopedic Surgery, Shinshu University School of Medicine, Matsumoto, Nagano, Japan. Departments of Orthopedic Surgery and Community Health and Preventive Medicine, Hamamatsu University School of Medicine, Hamamatsu, Shizuoka, Japan. And the Medical Affairs Department, Pharmaceutical Business Administration Division, Asahi Kasei Pharma Corporation, Tokyo, Japan. For elderly patients, posterior lumbar interbody fusion, or transforaminal lumbar interbody fusion, is usually performed to treat lumbar degenerative diseases. However, some patients exhibit pseudoarthrosis following such procedures. The anabolic agent teriparatide is an approved treatment for promoting bone formation in osteoporotic patients. The author's multi-center prospective randomized study assessed the role of once-weekly teriparatide administration on patient outcomes following interbody fusion. Patients were females who were 50 years of age or older, had a bone mineral density of less than 80% of the sex-matched young adult mean and/or previous spinal compression or femoral fractures, and had lumbar degenerative disease. Patients were randomly allocated to receive either weekly teriparatide, administered subcutaneously starting at week 1 for 6 months postoperatively, the teriparatide arm, or no teriparatide, the control arm. Blinded radiographic evaluations were performed using dynamic radiography and computed tomography, CT, and assessed by modified intention-to-treat analysis and per-protocol analysis. Clinical and neurological symptoms were evaluated using the Japanese Orthopedic Association Back Pain Evaluation Questionnaire, JOA-BPEQ, and the Oswestry Disability Index, ODI. 75 patients were randomized to treatment, and 66 patients completed treatment. At 4 months postoperatively, bone fusion in the 2-center CT slices was significantly higher in the teriparatide arm compared with the control arm in the age-adjusted, modified intention-to-treat analysis, and was significantly higher at 6 months in the per-protocol analysis. Radiographic examinations showed no disc space narrowing and no intervertebral disc instability. JOA, BPEQ, and ODI results were improved postoperatively in both treatment arms. Conclusions. Weekly administration of teriparatide promoted bone formation at the surgical fusion site and decreased bone resorption as indicated by bone metabolic marker results within the early postoperative period. The author's findings suggest that combining lumbar interbody fusion and teriparatide treatment may be an effective option for managing lumbar degenerative disease in elderly patients. Next, you'll hear the fourth abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Dynamic Stress Testing is Unnecessary for Unimalleolar Supination External Rotation Ankle Fractures with Minimal Fracture Displacement on Lateral Radiographs by Dr. Simo Nortonen and Associates. Investigation performed at the Department of Surgery, Oulu University Hospital, Oulu, Finland, and the Division of Orthopedics and Traumatology, Department of Trauma, Musculoskeletal Surgery and Rehabilitation, Tampere University Hospital, Tampere, Finland. This study aimed to identify factors from standard radiographs that contributed to the stability of the ankle mortise in patients with isolated supination external rotation fractures of the lateral malleolus. Non-stress radiographs of the mortise and lateral views without medial clear space widening or incongruity were prospectively collected for 286 consecutive patients, including 144 female patients and 142 male patients from 2 trauma centers. The radiographs were analyzed for fracture morphology by 2 orthopedic surgeons who were blinded to each other's measurements and to the results of external rotation stress radiographs, the reference for stability. Factors significantly associated with ankle mortise stability were tested in multiple logistic regression. Receiver operating characteristic analyses were performed for continuous variables to determine optimal thresholds. A sensitivity of greater than 90% was used as the criterion for an optimal threshold. According to external rotation stress radiographs, 217 patients, 75.9%, had a stable injury, defined as that with a medial clear space of less than 5 millimeters. Independent factors that predicted stable ankle mortise were female sex, a posterior diastasis of less than 2 millimeters, corresponding with a sensitivity of 0.94 and specificity of 0.39 on lateral radiographs, and only 2 fracture fragments. When the posterior diastasis was less than 2 millimeters and only 2 fracture fragments were present, the probability of a stable ankle mortise was 0.98 for 48 female patients and 0.94 for 37 male patients. Conclusions. Patients with non-comminuted lateral malleolar fractures could be diagnosed with a stable ankle mortise without further stress testing when the fracture line widths were less than 2 millimeters on lateral radiographs. Next, you'll hear a commentary by Dr. J. Lawrence Marsh on the article entitled Dynamic Stress Testing is Unnecessary for Unimalleolar Supination External Rotation Ankle Fractures with Minimal Fracture Displacement on Lateral Radiographs.
This is Larry Marsh providing commentary for the March 2017 JBJS podcast. I will be providing commentary on the article entitled Dynamic Stress Testing is Unnecessary for Unimalleolar Supination External Rotation Ankle Fractures with Minimal Fracture Displacement on Lateral Radiographs. The title of my commentary is Which Lateral Malleolar Fractures Do Not Need an Operation? The best and most cost-effective treatment of lateral malleolar fractures without talar displacement on presenting radiographs remains controversial. There is one thing that is not controversial. They do not all need an operation. But how do you decide? What assessments are necessary, and what criteria should be used to help make this decision? That is the controversy. The articular cartilage of the ankle joint does not tolerate a wide mortise. The most common cause of a chronically wide ankle mortise is an unstable rotational ankle fracture healed in an incompletely reduced position. When this occurs, loss of cartilage, pain, and decreased function are predictable results. To minimize the risk of malreduction, most unstable ankle fractures are surgically reduced, and the malleoli and syndesmosis are internally fixed as necessary to restore the mortise and to minimize talar instability. There is good evidence that after some lateral malleolar fractures, the mortise remains stable, the talus does not shift, and excellent outcomes result from simple treatment without a surgical procedure. Distinguishing between stable and potentially unstable ankle fractures has been the subject of a number of studies. These include studies on the value of the clinical examination and magnetic resonance imaging. But most of these studies have indicated that dynamic stress radiographs or weight-bearing radiographs designed to directly demonstrate instability of the talus are necessary. Different stress techniques have been described, and controversy remains regarding how much shifting of the talus constitutes instability and the need for an operation. In the article entitled Dynamic Stress Testing is Unnecessary for Unimolecular Supination External Rotation Ankle Fractures with Minimal Fracture Displacement on Lateral Radiographs, Norton et al. Propose that stress radiographs are not always necessary and that in some fractures there are radiographic signs of ankle stability on presenting radiographs that can be used to guide treatment decisions without performing stress radiographs. For the study, measurements made on the presenting radiographs of a large series of supination external rotation ankle fractures that did not have talar displacement were correlated with ankle stability or instability assessed on stress radiographs. 76% of the ankles were stable, defined as less than 5 millimeters medial clear space widening on stress radiographs, and 24% were unstable. Norton et al. Found that in non-comminuted lateral malleoli, when there is posterior displacement of the fibula of less than 2 millimeters on the lateral view, the ankles were stable to stress testing. These findings occurred in nearly 30% of patients. According to this study, these patients can be predicted to have stable ankles on the basis of injury radiographs and do not need stress testing. Clinicians should consider a couple of important points when incorporating these results into practice. First, less than 2 millimeters posterior displacement predicts a stable mortise, but many lateral malleoli with greater than 2 millimeters of posterior displacement will have stable ankles on stress testing. Displacement by greater than or equal to 2 millimeters of the fibula fracture on the lateral view should be used as an indication for a stress view and not for a surgical procedure. Second, the study design compares a radiographic measurement on injury radiographs with a radiographic measurement on a stress view, not with an important clinical outcome. A mortise shift of 5 millimeters on an external rotation stress view was used as a reference for ankle instability. Norton et al. Correctly point out that there is insufficient evidence to know the medium or long-term prognostic value of this test or other tests of dynamic instability and whether the decision to operate or not on the basis of this assessment leads to the best patient outcome. This study identifies a subset of patients with lateral malleolar fractures without talar displacement for whom a simple radiographic assessment without dynamic stress testing should be safe and effective to determine that an operation is not necessary. This study does not help to identify which patients require surgical reduction and fixation for an optimal outcome. Thank you.
Next, you'll hear the last abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Efficacy of Surgical Site Multimodal Drug Injection Following Operative Management of Femoral Fractures, a randomized controlled trial by Dr. Daniel Kohler and Associates. Investigation performed at the Department of Orthopedic Surgery and Rehabilitation, University of Iowa Hospitals and Clinics, Iowa City, Iowa. Multimodal analgesia, inclusive of periarticular injection with a local anesthetic agent, has been rapidly assimilated with demonstrated safety and efficacy into the care of patients undergoing elective lower extremity arthroplasty. The present study was performed to evaluate the efficacy and safety of a surgical site multimodal drug injection for postoperative pain control following operative management of femoral fractures. There were 102 patients undergoing operative intervention, plate fixation, intramedullary device, or arthroplasty for a broad range of femoral fracture patterns who were prospectively randomized either to receive an intraoperative surgical site injection into the superficial and deep tissues containing ropivacaine, epinephrine, and morphine, or to receive no injection. Visual Analog Scale, VAS scores, were recorded at regular intervals as the primary outcome measure. Narcotic consumption and medication-related side effects were also monitored. The injection group demonstrated significantly lower VAS scores than the control cohort in the recovery room and at the 4, 8, and 12-hour postoperative time points. The median score was 1.6 for the injection group and 3.2 for the control group immediately postoperatively, 1.0 for the injection group and 5.0 for the control group at 4 hours, 2.0 for the injection group and 5.0 for the control group at 8 hours, and 3.5 for the injection group and 5.0 for the control group at 12 hours. Additionally, narcotic consumption was significantly lower in the injection group compared with the control group over the first 8 hours following the surgical procedure. No cardiac or central nervous system toxicity was observed secondary to infiltration of the local anesthetic. Conclusions. Surgical site injection with a multimodal analgesic cocktail provides improved pain control and reduces narcotic utilization over the first postoperative day, with no observed adverse effects attributable to the local injection across a diverse orthopedic trauma population undergoing operative intervention for femoral fractures. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.